Hi there, my name is Ellen Van Druten, and welcome to a presentation on the Affordable Care Act and Public Health. In order to understand the current climate of our health coverage, it's important to understand the basics of our nation's healthcare delivery. We have a dispersed healthcare system here, meaning a free-flowing structure with increased patient autonomy, allowing the patient to enter the system at any level. For example, if a patient has been having headaches, they have the option of going directly to a neurologist versus going through the system through their primary care doctor. Financially, we have a hybrid system, which is somewhere between a single-payer and multi-payer system. This is unique when compared to other industrialized countries like Canada, for example, that has just one health insurance option fully funded by the government, or the Netherlands that have multiple health coverage options, all funded by the government as well. Because the U.S. has a hybrid system, there are both public and private insurances available for citizens. Here are a few examples: Medicare and Medicaid being public health care coverage, and private health care coverage, including some of the big insurance companies. Our unique healthcare system does come with a few strengths and weaknesses. Strengths include no boundaries in seeking specialists at the hospital level. For example, if a patient presents to the ER with chest pain, a cardiologist can be consulted quite easily. This can be a challenge for other systems at times. We have substantial competition for the latest and best care, and both of these together create a patient-centered system. Weaknesses include a top-heavy system, which is marked by a primary care physician shortage due to the appeal of becoming a specialist. This has left lower socioeconomic areas without proper access to primary care, and our balance of spending and healthcare outcomes could use some improvement. With that said, we can now take a look at the Affordable Care Act and its influence on our healthcare system. The Patient Protection and Affordable Care Act officially is commonly referred to as the Affordable Care Act, the ACA, or Obamacare, and it is the healthcare reform legislation implemented by the government in March of 2010. Here are some of the main components. The central aim is to achieve near universal health coverage. There's also the goal to improve fairness, quality, and affordability of health insurance. It hopes to invest in the public's health through clinical care in the communities, as well as improve value, quality, and efficiency, reduce wasteful spending, and increase accountability. And it hopes to strengthen access to primary care and increase preventative health care. Structurally, the ACA created healthcare exchanges detailing coverage options from state to state for both individuals and small businesses. The information was compiled on a website, serving as a one-stop shop for a summary of benefits and of participating health plans, bringing health insurance accessibility into the 21st century. The delivery of healthcare in the U.S. has since been influenced by the ACA in two major ways: increased efficiency and prioritization of prevention. In each of these areas, as detailed here, new initiatives and funding were established to bring change to Medicare and Medicaid, improve access to information technology across insurance companies, and increase coverage of preventative services for individuals, as well as increase funding for prevention and response efforts on a national level. Now, we can look further into the ACA and address a few strengths and weaknesses of the program and how it compares to the healthcare services of another nation. Without question, the ACA has improved access to healthcare. The gap between white and minority health coverage has narrowed. 3 million Americans were able to gain coverage by being allowed to stay on their parents' health plan until age 26, and those with pre-existing conditions could no longer be denied coverage. Outcomes have also improved as Medicare patient readmission and hospital-acquired conditions have both decreased. An interesting fact is that due to the hospital-acquired condition decline, it's estimated that 50,000 deaths were prevented and $12 billion in healthcare spending was saved. Weaknesses of the ACA include possible overambition and the cancellation of several million Americans' health plans. There were a few unfulfilled promises by the ACA, and millions of people were dissatisfied when they were happy with their previous health coverage. Even to this day, some people are still dissatisfied with the legislation overall, despite the successes that we just discussed. Now, when we compare the ACA in our current healthcare climate to the UK, for example, how do we measure up? While we have the dispersed healthcare system, the UK has a regionalized system which is characterized by 3 tiers: primary, secondary, and tertiary, requiring the patients to proceed through those tiers in that order. This system has proven successful in the UK in more ways than one. The UK spends about a third of what the US does per capita on healthcare, but they have better health outcomes, particularly in the areas of life expectancy, infant mortality, chronic disease prevalence, and the prevalence of obesity. This goes to show that the US may be able to learn from the UK's NHS. With all of this said, the field of public health as a stakeholder in the health of the United States must be in close relationship with the healthcare field. This is a relationship that should be and continue to be rooted in prevention at both the local and national levels. Let's look at cigarette smoking as an example. We know that cigarette smoking is a national problem here in the US, as 14% of the population smokes cigarettes. There are 2 approaches that can be taken to address the problem: curative or preventative. The curative approach would treat the negative side effects of smoking after they've already occurred, such as high cholesterol. The preventative approach would work toward preventing smoking altogether in order to prevent illness down the road. Prevention has been proven to be more cost-efficient than curative care, as proven by a study done by the Surgeon General. And shown through the cigarette smoking example here, we see that $2,000 per smoker might be saved per year in healthcare costs by implementing tobacco cessation programs. This exemplifies the importance of the relationship between healthcare delivery and public health because it benefits the government financially and it benefits the health of the public overall. All of this information matters in order to best inform the future of healthcare delivery and public health. These 3 recommendations for the future are just a few ways that we can ensure progress in our healthcare system for the betterment of our nation's health as a whole. They include, but are not limited to, further developing the relationship between healthcare and public health with prevention as a priority, as shown successful in the previous slide. The aforementioned primary care physician shortage might be addressed by developing further incentive programs for future physicians. And while we know that policy change is inevitable, as a nation we must strive to maintain what currently works and has made a positive influence on healthcare access here, while working to improve the weaknesses for the sake of America's health now and tomorrow. So I thank you so much for joining. Hope you enjoyed the presentation. And here are the sources for the information we discussed. Thanks again and have a great day.